Abdelhamid. He got the medical Bachelor of Medicine in December 1997 and the Master degree in General Surgery in November 2001, an MD in General Surgery in November 2008, and he was Assistant Professor in Pediatric Surgery from 2009 till 2014. And he's a Professor of Pediatric Surgery in Ain Shams University from 2019 till now. Welcome, Dr. Amr. We are honored to have you in our review course. Thank you very much.
Thank you very much. Thank you for your invitation. Thank you very much. Thank you very much. I have just seen that you have in the previous lecture, Dr. Punar was speaking about the esophageal atresia, management of the long gap, and several tricks to trying to save the native esophagus, maybe traction and maybe esophagoplasty. However, some cases these tricks may not function, and you may need at the end to do some sort of esophageal replacement. Another part of this presentation would be about the caustic injuries to the esophagus and the plan for esophageal dilatation. So these are two parts in this lecture today, and we will start by the first part. I would like to acknowledge the slides of this first part belongs to my dearest colleague, Dr. Khalid Al-Asmar. He's professor at Ain Shams University, and he has special interest in managing caustic strictures at our unit. And of course, to have some overview, caustic injuries, liquid caustic injuries have been a great problem in my country over the past years. Fortunately, this has been much decreased recently due to the efforts to increase the awareness of the population about the hazards of these caustic liquids using in houses. And also, we have developed a more effective dilatation program, as you can see from our publications over the last years. So in the acute management of caustic ingestion, also, I would like that our unit has this opportunity because early we had a very establishing a toxicology unit which was training these patients with caustic injuries from all over the nation. And this was an advantage that our center at Ain Shams has this experience both in managing caustic strictures and in esophageal replacement procedures. So in the acute management of caustic ingestion, don't forget the ABC for acute trauma, vascular stability. After early management and improvement of the oropharyngeal acute burn and pain relief, we assess the patient. Either those are tolerating oral feed, they can and have stable general conditions, they can be discharged. Those who are not tolerating, we may need early feeding gastrostomy. The early endoscopic management of caustic strictures, esophageal caustic strictures, is well known in the literature. However, at our center, we do not do this or practice this early endoscopic management of the caustic strictures. And of course, we can use either the flexible endoscopy or the rigid endoscope. And usually we start the endoscopic dilatation 6 weeks after ingestion of the caustic agent. These are the two methods for dilatation. There's a varicular dilator using the guide wires or the balloon dilatation. And we have developed a more strict protocol for dilatation to avoid the restriction and to decrease the need for esophageal replacement procedures. We start every 2 weeks endoscopic dilatation sessions for first 3 months, and then every month for the next 3 months, and then every 2 months for another 6 months. Of course, this will depend on the patient symptom, but this is we need to regular endoscopic sessions, especially early, to avoid the restriction and the recurrence of dysphagia. We need to have safe dilatation. For this reason, we always start 6 weeks after caustic ingestion. I know this is not the gold standard, and maybe their other centers may do early dilatation, early stent placement, but this is our protocol. We use guide wire. We don't do blind dilatation, and we use fluoroscopic guidance and appropriate size, and avoid excessive force. Of course, we should be aware of the complications which after dilatation, which is perforation of the esophagus. As we have seen in the previous lecture, trying to preserve the native esophagus. However, I have a comment that we have to try to preserve the native esophagus, but we have to preserve it in a functional way. Sometimes you may do many procedures, but that will save the native esophagus, but it will not be well functioning. Another way to try to, in addition to the regular dilatation, we are using application of drugs like mitomycin C. These also have been shown to decrease refibrosis and restructuring after dilatation. And these are my colleagues have these studies published. Also, sometimes failure of passing the guide wire through the pharynx, we may shift to retrograde endoscopic dilatation. And as you can see, this case, the stricture is twisted and it's not straight, and this could not be manipulated from above. However, we could remove the gastrostomy tube and insert the endoscopy from below and do retrograde dilatation for this stricture. So this was an overview about the caustic strictures, and as I said, we had to have many cases, and fortunately, these have been much decreased over the last years. Maybe now we are more prevalent with foreign body ingestion batteries in the esophagus, and we have a marked decrease in the frequency of liquid corrosive esophageal strictures. And now we may shift to a very important topic, and again, this esophageal replacement. We are at my unit, successive generations were involved in doing many cases of esophageal replacement, and since we have started, the colon remained the first and maybe the only choice to replace the esophagus. Generations after generations. And so, as you have seen in the previous lecture, the long gap esophageal atresia and resistant corrosive strictures are the two main indications for esophageal replacement in pediatrics. Different organs and procedures are available for substituting the esophagus, the stomach, the colon, the jejunum, and maybe the ileum. And in the literature, there is no privilege for one technique over the other. Each center is reporting its own experience and its own preference, and there is lack of comparative studies to show a privilege of one technique and one organ over the other. However, at our center, we always prefer the colon for several reasons: the stable vascular anatomy and the plenty of tissues, and we can use the part of the colon to replace the whole esophagus, and we have the rest of the colon without compromising the lower gastrointestinal tract function. On the other hand, we believe the stomach is a very peculiar organ among the gastrointestinal tract, that it should not be used as a first choice to replace the esophagus. And it's in the textbook of the pathology, I have read a very important statement which says that although the stomach is a non-vital organ, a well-functioning stomach has been shown to be very essential for the human well-being. This was very clear during the era where there were surgery for the peptic ulcer used to do gastrostomies, vagotomies, and these have shown that a very bad effect on the patient health and the digestive tract. So we prefer to preserve the stomach and not to use it as a replacement for the esophagus. This is a statement also by Dr. Dimasiter, a famous adult esophageal surgeon, who said that the demanding technical expertise required and the additional operating time needed for performing a colon interposition is more than compensated by its durability and function. And actually, the durability and function but makes colonic replacement of the esophagus more preferable for the pediatric patients because of their long life expectancy. We can have some controversies regarding the colonic replacement of the esophagus, choosing which colonic segment to replace the esophagus, whether to use the right or the left colon. It is a controversy between different centers. The position of the graft and the route for the colon in the thorax, whether in the anterior or the posterior mediastinal route, and necessity of removing the scarred esophagus in cases of post-corrosive strictures when we choose a retrosternal colon bypass procedure. And lastly, the mechanism of prevention of regurgitation of the gastric contents into the colonic flap. So let's start by choosing the colonic segment to act as a substitute for the esophagus. By revising the vascular anatomy of the colon, we have the three main arteries: the right colic, the middle colic, and the left colic. And vascular anatomy, there is a very good collateral circulation and communication between the three main arteries of the colon. So the marginal artery, our preference and the classic and typical flap preparation will depend on by dividing the middle colic artery, middle colic vessels below the bifurcation, to ensure that the blood flow will pass through the marginal vessels to the end of the most proximal end of the colonic flap, and therefore this flap will be based on the left colic vessels. Sometimes if we need a longer flap, we can also ligate the right colic vessels below the bifurcation, and the continuity of the gastrointestinal tract will be restored by the colocolic anastomosis after isolation of the colonic flap, well vascularized pedicled flap based on the left colic vessels. And this is the operative field, how to prepare the flap. This is the left colic vessels, as you can see, a stable vascular anatomy, ligation of the middle colic vessels below the bifurcation to maintain the blood flow through the marginal vessels. And here you can see the colonic flap can traverse the thorax to the esophagus for the anastomosis. So you may face some variation in the vascular anatomy, especially of middle colic vessels. Most commonly is you have a single middle colic vessel, and here you will do a single ligation below the bifurcation, as in this case. We may have a double middle colic vessels, and no problem, you will do ligation below of the two middle colic vessels below the bifurcation. And again, you can see here a viable flap based on the left colic vessels. A much rare variation is the congenital absence of the middle colic, and this is considered a favorable variation. As you can see, the marginal vessels will be well developed and running parallel and close to the mesenteric border of the transverse colon, and this facilitate and ensure a very well vascularized colonic flap. This is how we measure the distance needed to traverse the cap through the thorax. You can see here that the distal end is usually fixed. It will be below the left colic vessel here. And this is close to the stomach, so this is not important. Usually this is a fixed point for dividing the flap. What we need is to determine the length of the proximal flap, and you can see here from the highest point of the transverse colon, we measure the distance needed and mark that. And as we have said, if a longer flap needed, we can also ligate the middle colic and the right colic vessel. So here, this is again the diagram to show how we isolate and prepare the well vascularized colonic flap, and how the vascular anatomy of the colon makes it a perfect substitute, well vascularized flap to replace the esophagus. In very rare occasions, we have faced a single case in 50 consecutive cases when the middle colic vessels were abnormal, formed of multiple and short vessels. with discontinuation of the marginal vessel in the mesentery of the transverse colon. And here we had to revert from the classic way of preparing the transverse colon flap and use the right colon. Also here, the colonic flap here is based on the middle colic vessels. So as also, and we have ligated the right colic vessels, and the cecum will go up to be anastomosed with the esophagus in the neck. And as you can see here, also we managed to make an isoperistaltic position of the colonic flap. And there are centers which are using the right colonic flap as routine, but we find it much easier to use a transverse colonic flap based on the left colic vessels. However, your knowledge about different types can save you in such and present a good escape for such a rare and difficult situation. Next point we may need to discuss is which is a better route for placement of the colonic substitute for the esophagus. This is a posterior route, the transhiatal colon interposition, and this is the retrosternal colon bypass. The transhiatal dissection and tunneling is more difficult. It is maybe performed in a blind way. There are the major vessels. The presence of the esophagus in post-corrosive strictures may help as a guide for dissection. So I have seen some of the surgeons with the introduction of the laparoscopy, they can do this transhiatal dissection under laparoscopic control. However, the transhiatal tunnel is much easier. It is very easy plane to dissect. The last part, which is behind the manubrium verni at the thoracic inlet, this is where the retrosternal muscles, can be performed under direct vision. We have to detach all the muscles from the back of the manubrium verni in order to avoid compression on the colonic flap at the abnormal thoracic inlet and abnormal new route for the colon. So in esophageal replacement in children, as it's always associated with benign disorders, therefore esophageal resection is not mandatory as in the adult when they are dealing with tumors of the esophagus. So we have found that we have been alternating between the transhiatal and the retrosternal route, but finally we have reached that our preference, current preference, is to do a retrosternal route, which saves a technically challenging step, which is esophageal resection, and considerably simplifies the procedure with comparable functional results. However, in post-corrosive strictures, there is some concern about the risk of malignant transformation in the retained esophagus and also mucus cyst formation. And this was one of our cases when we did a retrosternal colon bypass for post-corrosive stricture. We have seen this cyst at follow-up. It represents the retained scarred esophagus, and this cyst can be, it is not common, but however, this cyst can be excised, and we can do it thoracoscopically. We believe that the retrosternal colon bypass procedure is most suitable for replacing the esophagus in long gap esophageal atresia and can also be an excellent option for post-corrosive strictures, but this should be complemented by long-term surveillance for any possible rare complications in the retained scarred esophagus. A next point of discussion would be the need for adding an anti-reflux procedure for colonic replacement of the esophagus. Early reports have highlighted the advantage of the colon for its claimed resistance to peptic ulceration. The colon is well known for its profuse mucus secretion, and this provides resistance to the acid secretion from the stomach. However, we have noticed that peptic ulceration is not the only problem related to gastrocolic reflux, and that significant regurgitation of the gastric contents into the colonic conduit can lead to other fatal respiratory complications in the early post-operative period and delayed complication related to the dyspepsia and the poor emptying of the stomach. Although Dahl and Schirman at Great Ormond Street first introduced the anterior retrosternal route for colonic replacement, they used the right side colon, and they performed the anastomosis anterior with the stomach. at the lesser curvature. However, in the adult literature, Belsey used the posterior mediastinal route, and he emphasized on the importance of performing the cologastric anastomosis on the posterior gastric wall in order to get benefit from the compression of the full stomach and the colonic conduit to prevent reflux. And we have modified and used a combination of the posterior cologastric anastomosis as recommended by Belsey with the retrosternal colon bypass, and we have found this is very beneficial not only in prevention but also for treatment of complications, delayed complications of gastrocolic reflux after colonic replacement of the esophagus. This is how we managed to perform the cologastric anastomosis in the posterior gastric wall. This is the colonic conduit passing behind the retrosternal tunnel, in the retrosternal tunnel, and this is the stomach. The greater curvature is elevated, and the cologastric anastomosis is performed to the back of the body of the stomach. The location it should be performed ideally in the back, away from the antrum and close to the greater curvature, in order to secure a segment of the colon under the weight of the stomach. And you can see here this contrast study, a part of the colon is behind the under the pressure of the stomach. As you can see, we have detected some complications related to placing the colonic anastomosis to the anterior gastric wall. Always there was a reflux, significant reflux. This was responsible for early respiratory complications and delayed complications related to dysphagia and colonic redundancy. However, when we shifted recently to the posterior cologastric anastomosis, this has greatly prevented reflux from the stomach to the colonic conduit. And these are example for one of cases who were performed in the past and presented with dysphagia and hematemesis. This was successfully managed by transferring the colon from the anterior wall of the stomach to the back of the stomach. And you can see here in the gastrogram, before operations, there was marked reflux, and after operation, marked improvement, radiological and clinical improvement for this child who gained weight and was relieved from his symptoms and hematemesis. This is another case, as you can see, how usually distended colon and redundant colon. Maybe we believe that the reflux, it's like in the ureter, it's like a yo-yo effect. The stomach is emptying into the thorax, maybe facilitated by the negative pressure. And this case again has been successfully managed by transferring the cologastric anastomosis from the anterior wall of the stomach to the back of the stomach with marked radiological and clinical improvement. We have touched the redundancy of the colonic graft. It's a major concern after colonic replacement of the esophagus. Maybe it is about 60% of cases. We have tried to do some grading for the redundancy of the colonic substitute in the thorax and in the abdomen. And several series have been proposed. Avoid using too long grafts and excise any excess length before completing the neck anastomosis. Also, we believe that major regurgitation of gastric contents into the colonic conduit would further aggravate existing redundancy through distension and through impairing proper gastric emptying through the duodenum. Lastly, I would like to discuss some of the complications which may be related to the procedure, colonic replacement of the esophagus, and it is dysphagia. As you can see, the upper row, there is, you can see here strictures at the site of the esophageal anastomosis. Beware that there is a natural here, below here, this is the narrowing is related to the thoracic inlet, and this is usually is not a cause of dysphagia. If you do, as we have mentioned before, you have to detach all the strap muscles from the back of the sternum, and these cases may respond to dilatation or may need revision of the neck anastomosis. I would like to emphasize that before surgery, you have here this patient have a long stricture and a stricture in the pharynx, and after colonic replacement, he still has dysphagia, which is still difficult to manage because there is no healthy esophagus, and the stricture is involving all the esophagus up to the pharynx, and this is a trap. You have to be aware of this problem before doing the esophageal replacement, because this patient will not benefit from doing such procedure, and this stricture should be managed by the ENT before you go to do a colonic replacement. So here again, this is the site of the esophagocolic anastomosis. This needs to be dilatation or revision. However, this narrowing is related to the flap passing behind the manubrium sterni at the thoracic inlet, and maybe you find another narrowing or when the colon passes through the diaphragm. Usually these do not cause dysphagia problems. The most problems result from the cologastric the esophagocolic anastomosis, and usually it is more common with the corrosive injuries because the esophagus is not so healthy, contrary to the cases of esophageal atresia. So maybe we will come to the end of the presentation, giving time for some questions. And these reports may be available for those who are interested for further details about the presentation. Thank you for your attendance, and I hope I would have tried to convey our experience in this particular subject in pediatric surgery. Thank you very much.
Thank you, Prof. Amr. Thank you very much for this nice and organized lecture. So now we have a question. We'll go for questions. First one, is it mandatory to do pyloroplasty in every case of esophageal replacement?
Yes. Thank you for this question. About the pyloroplasty in retrosternal colon replacement, we usually do not need to do pyloroplasty. Pyloroplasty was used as a routine when we used to perform colon interposition, and we do transhiatal excision of the esophagus, which is sure we will have to do vagotomy. So in the time we were doing the pyloroplasty, we used to do routine pyloroplasty when we used to do transhiatal colon interposition and esophageal resection. As this step is sure we associated with vagotomy when we do resection of the injured esophagus and we do transhiatal esophageal replacement. Now when we do so it was a routine to do a pyloroplasty. Now we do the retrosternal colon replacement, colon bypass. We do not need pyloroplasty. We do not do it with the retrosternal colon replacement.
The next question about the best conduit for esophagus is esophagus itself. So the question is about the esophageal stent. Is it an option to avoid esophageal replacement?
Yes, we don't have this experience. I know there is centers which do early endoscopy, early in the acute phase of the caustic injury. During the acute phase, they do endoscopy and they assess the mucosal injury and the degree of the burn of the esophagus, and they may decide to put a stent to avoid stricture. Unfortunately, we do not have this experience, but we agree that we need to preserve the native esophagus. The first step is prophylaxis and to avoid the injuries, and we have succeeded in this to a great extent with liquid corrosives. During the last years, we have marked decrease in these patients by prophylaxis. The next step is to whether to do early endoscopic or to do strict endoscopic programs for dilatation using drugs like mitomycin C or steroids, and we leave the replacement to be a last resort. But I would like to, I have seen the previous presentation, when you do, for example, in the long gap esophageal atresia, you do much stretching and do under tension and Cooley's esophagoplasty. I don't have this experience, but I believe that you have to preserve a function esophagus, not just to preserve the esophagus with a poor function and with reflux and with Barrett esophagitis. So don't struggle too much for or you will lose the battle at the end.
Okay, the next question, what is the preferred age for esophageal replacement for long gap tracheoesophageal fistula?
The best conduit, the best conduit.
No, the preferred age, you mean?
Preferred age, yes, the preferred age. Usually we will not do it before 6 months of age. I think maybe after 1 year, we had many complications when we're doing in infancy, but it was due to the reflux. And when the infants are the protective mechanisms in the infants for the reflux is poor, and but after 1 year, when they apply, when they have erect posture, they can sit. This may be much less liable for the respiratory complications. But nowadays, by shifting to the technique of anti-reflux, maybe we can go for earlier age. But I think not before 9 months of age.
Okay, the next question about feeding protocol post-colonic interposition.
In the early post-operative period, we usually leave the gastrostomy till we make sure that we leave it for about 3 months, till we make sure that the child is able to take all the oral intake from their mouth and he has no strictures, no difficulties. Then we just remove the gastrostomy. Now we prefer to do a gastrogram before removing the gastrostomy when we check for the reflux, because it's much easier when you have the gastrostomy to see if there is reflux or not before removal of the gastrostomy. So for the early, we start usually on the 7th post-operative day by feeding through the gastrostomy, and gradually we shift to oral feeding. One of the common complications is that you have dehiscence in the neck anastomosis, because this is the proximal part of the colon. It is the most far point from the vascular pedicle. It is about in 20% of cases we may have disruption in the neck anastomosis, but this is usually heals spontaneously. In these cases, we will delay the oral intake until healing in about 4 to 6 weeks, and then we will resume the oral intake.
Next question is, what is the workup for stricture length? Is it short or long? And what is the treatment for both?
Yes, the stricture length, sometimes it is difficult to assess through the radiology because a narrow stricture, a high stricture will prevent normal filling of the esophagus below. So this will be best performed after the first dilatation, when you can go down and see the stricture and assess the stricture with the endoscopy. Of course, the long stricture may be more difficult to treat. Really, my colleagues, Dr. Khalid, has great interest in this and in this topic and the colonic dealing with caustic strictures, and he has several publications regarding this issue. But we will try, and the patient response will declare what we need to do next.
Okay, the question about your experience about the esophageal replacement with small bowel.
Yes, I know that I have one of our colleagues, Dr. Muhammad Samih, is now consultant in UK. We meet him frequently, and he has been discussing that their centers, they use the jejunum. I have no experience. I think the most common in the literature is colon and stomach, but it's difficult to judge on evidence base which is the best substitute, because each center there is no comparative studies and systematic reviews showing comparable results between different substitutes. But in our experience, we have successive generations, years after years, we have been modifying the colonic replacement and each generation adding some modifications that had at the end to decrease the time, to decrease the early post-operative complications, and to improve the functional outcome. And we are at my center, we are very satisfied with the colon.
Next question is, how often esophageal replacement is needed for corrosive injury?
Yes, actually, I can't answer exactly this question, but before 10 years ago, you can find this in our publications. The colonic replacement, the main population was corrosive injuries. About 80% of the colonic replacement was for corrosive injuries patients. Now it is reversed. in our recent years, much decreased, and maybe it is reversed. It's about 25%. Maybe it's the corrosive patients represent in the population for colonic replacement. Actual percentage, I can't guess.
Okay, I have three questions about the surgical technique of esophageal dissection and anastomosis, and the how to perform neck anastomosis. Can we just have a small steps how to perform the...
I will open just a picture, another picture to show the neck anastomosis, and I will share the screen. We do also this neck anastomosis. It is, I know it's a very good question, because the neck anastomosis is usually liable for wound disruption of the anastomosis. We have found that to occur in about 20% of cases. At first, in the past, we used to do an end-to-side anastomosis, but now we prefer, as you can see in this demonstration, this is in the neck wound. This is a neck wound. Below here is the colon, the proximal end of the colon, and above here the esophagus. We do incision in the anterior wall to spatulate the esophagus to compensate for the discrepancy between the both lumens. We do the posterior wall from inside, and we have to take the mucosa of the esophagus, and we do full thickness inside the posterior wall anastomosis for ovicular, and then we do the anterior anastomosis. We have, as I said, you can see here in this gastrogram, you may see a narrow leak here. This occurs in about 20% of cases. This is usually it heals spontaneously. Sometimes it may end with a stricture, but by doing this anastomosis in this way, we have managed to decrease the delayed complications in the neck. But another point, it's important when you are doing the dissection of the tunnel, the retrosternal, you have to detach all the muscles from the back of the manubrium to have a wide hiatus at the thoracic inlet, because if it is narrow, it will cause compression and congestion of this weak point of the flap. And this also will decrease complications at the anastomosis in the neck.
Okay, the next question is, when you plan for contrast study postoperative?
Yes, usually we may start feeding on the 5th to the 7th postoperative day through the gastrostomy. Variants, a water-soluble contrast study, we can perform it on the 7th to the 10th day. If everything is okay, we can start oral feeding. If we have any problems, we can delay the oral intake. And we have no problems. The patient can be discharged even if he has some leak from the neck anastomosis, and he can complete feeding through the gastrostomy. At first, when we had reflux when we were doing the cologastric anastomosis with the anterior gastric wall, reflux would cause the feeding to get up through the neck anastomosis. And this, even we could not feed these patients early through the gastrostomy when there was reflux. But nowadays, we don't have problems with reflux, and this is again, so the reflux, early they said that the colon, there is no problem with reflux. There is plenty of mucus secretion which can face the acidity of the stomach. Reflux of the gastric, regurgitation of the gastric contents have many problems, and now we have been very satisfied with this later modification. And usually we leave the gastrostomy for 3 months to be sure for the oral intake is well, no dysphagia. And then we do a second, we start the second contrast study, a delayed contrast study. We start by gastrogram so that the reflux is very clear, and contrast swallow, and be sure that there is no strictures in the above anastomosis.
The last question is, do you do gastrostomy in all cases?
Usually we have gastrostomy for long gap, failure of long gap in esophageal atresia. Usually this is a clear indication that the patient will have a gastrostomy, and this will be, he will be using the gastrostomy till the age which is suitable for doing the colonic replacement, maybe at 9 months of age. In cases of corrosive strictures, usually these patients with resistant and recurrent strictures, usually also they would have gastrostomy already inserted for improvement of their general condition and nutritional status before doing the colonic replacement. So always, I don't remember that we had performed a colonic replacement in a case without a gastrostomy, and we usually do not dismantle the gastrostomy. We leave the gastrostomy, and actually sometimes the gastrostomy, one of the indications to shift to the back of the stomach for the anastomosis, it was by chance that sometimes when we wanted to do the cologastric anastomosis, the gastrostomy in the anterior wall of the stomach hindered the anastomosis. So we thought that we can shift it back to the back of the stomach, and we have all the back of the stomach, the back of the body of the stomach. It's free to put the anastomosis very easily, and this was the beginning of our shift. And later we have seen that was very beneficial in prevention of reflux.
Thank you, Prof. Amr Abdelhamid. Thank you very much for this informative lecture. Really, we enjoyed it all. Thank you very much, Dr. Amr Abdelhamid. He's a professor in pediatric surgery in Ain Shams University. Again, thank you very much. Hope to see you soon, inshallah.
Thank you very much. Thank you very much. Wishing you all the best of luck and success, and to complete your course. And thank you very much for inviting me and giving this chance. Thank you very much.